what is the role for antithrombotic therapy? What is like actually the pathophys? Is it like preventing future plaque rupture? What's kind of going on there?
Antiplatelet therapy for peripheral artery disease is primarily indicated for anybody with symptomatic disease, usually a baby aspirin. There is a level 1 recommendation currently for Plavix to be used interchangeably with aspirin based on some prior data. But most often, just having a patient on a baby aspirin is reasonable. And my feeling is if you have a diagnosis of peripheral artery disease, I think it was a secondary, not primary indication for aspirin therapy because I'm diagnosing you with an atherosclerotic condition. So I really try to pull the trigger early to put them on a baby aspirin. Escalation after there is really dependent on what happens next. So you're going to hear a lot more and have potentially already heard a lot more about the use of anticoagulants for peripheral artery disease. Before I jump into that, I get a lot of questions about dual antiplatelet therapy. And for the average patient who has not had been treated with anything like recently, either a coronary stent or a lower extremity procedure, there is really no role for dual antiplatelet therapy. So we don't really advocate for people to be on aspirin and Plavix for years upon years. There's no great data to support that. Now, if you had a coronary stent, you should do your dual antiplatelet therapy as indicated for your coronary stent or ACS event. And if you have a lower extremity intervention, you'll see that we put people on dual antiplatelet therapy for a certain amount of time after the procedure, depending on what was done. But really over the long term, and usually no more than 6 to 12 months, people really do not need or have any real proven value of being on long-term dual antiplatelet therapy. And that's already been represented in the guidelines. The bigger introduction into the peripheral vascular space that has made a big impact is low-dose antithrombotic therapy, in particular rivaroxaban. And so rivaroxaban, or Xarelto, if people are familiar, has been primarily been used for venous thromboembolism, atrial fibrillation. We know that it's factor Xa inhibitor and it really has been successful at reducing the risk of thrombotic events. Now, it's been trialed in coronary intervention and trying to reduce post-cardiac, post-ACS events and actually showed some benefit. Just there was some trouble with some of the trials supporting it and didn't get the full indication in that context. But we learned from the COMPASS trial that was published several years ago that if you randomize patients to a low-dose rivaroxaban with aspirin, you can reduce cardiovascular risk, including cardiovascular death, over the long term. And a sub-analysis of that showed that, in particular, when you look at legs, people not only get the cardiovascular benefit, but they have lower risk of amputation and acute limb ischemia. And so the low-dose Xarelto theory comes that we spend so much time trying to shut down platelets based on what we know about coronary intervention and the mechanism of heart attacks. But in the leg, we don't really see that classic plaque rupture. That's not a conversation we talk about. It's really occlusive disease. But a lot of the patients that we've seen transform from a stable claudicant to someone with wounds and ulcers, critical limb ischemia, is potentially driven by either in situ thrombosis or arterial to arterial thrombosis. So some of the data came out of Sinai that looked at the legs of patients who underwent amputations for critical limb ischemia, and they looked at the vascular system on autopsy and found that a lot of patients who went on to have critical limb ischemia, the vessels that were involved actually didn't have significant atherosclerotic disease, but had thrombotic material in them. And so the theory again was that either a slow state where after you have a lot of proximal stenoses can lead to slow flow and thrombosis formation, or there was some migration of thrombus forming above and migrating distally. And so that's really driven this kind of dual pathway inhibition idea in the peripheral vascular space, that the low-dose anticoagulant can help not only prevent the potential cardiovascular events, but also the limb-related events. Now, there's a little bit more to unpack there, but I want to make two more comments. There was a follow-up study called VOYGAR PAD, and this was published in New England Journal of Medicine. Mark Banaka and Will Hyatt out of Colorado ran this trial, and there wasn't a great uptake of Xarelto 2.5 milligrams twice a day after COMPASS, and people were really trying to figure out what the right opportunities were to make impact on intervening and starting this therapy. And Voyager was a great trial because there was a lot of great mechanistic data talking about how both antiplatelet and antithrombotic can be important components to improving outcomes. So I ran a trial and they randomized people at the time of needing a revascularization, whether surgical or endovascular. So both patients were in that trial, whether claudication or critical limb ischemia. and you're randomized after your treatment to either Xarelto 2.5 milligrams twice a day with aspirin or aspirin alone. Each arm could use clopidogrel if they wanted to, but they weren't obligated to. And the take home from that trial was if you were randomized to the intervention arm, the low dose Xarelto arm, you had what we expected from the COMPASS trial, a better reduction in global cardiovascular events as well as limb-related events after your treatment. And so we've really adopted this in the peripheral vascular space where we try to get patients on low dose Xarelto, 2.5 milligrams twice a day. And how I think about it is it's hard to put everybody on that agent right now because we know polypharmacy is a big issue. They're on 5 agents for diabetes now. Everybody's on Ozempic or some, a weight loss drug, and then there's everything else that they have to use for their other comorbidities. So we always prioritize it in people with polyvascular disease. If they've had a heart attack and have symptomatic peripheral artery disease, that's a slam dunk in our clinic to start them on low dose Xarelto. If they've had a stroke and symptomatic peripheral artery disease, or all three. And so we really try to get that population, and then also the younger population, the population that's going to get the most benefit over the long term. If you're coming in a younger age with very symptomatic peripheral artery disease, you have to assume they have coronary artery disease, and we like to put them on that agent. If you're going for revascularization, we make it even more imperative that we try to get them on that agent. And so, as I mentioned, there are people who will be on dual antiplatelet therapy after a stent or balloon to their leg or bypass surgery for some time. But we try to, at least by 3 months, to get them off the Plavix and replace that with Xarelto 2.5 milligrams twice a day. Now, the barriers to that are still, one is accessibility and the pay, and that's getting better, but there's been patients whose copay is too high to be able to support it. And then there's also medical confusion. Like a lot of people think that Eliquis 2.5 milligrams twice a day is Xarelto 2.5 milligrams twice a day. And no one's actually tested that in Eliquis to date. So it may be true that they get the same benefit, but we try really hard not to do anything off label with this.
So moving on to the next category of medications for lipid therapy, so everyone needs to be on a statin. With that, is there an LDL goal that you target, or what's kind of the approach to lipid therapy?
I've kind of been in that mindset where if you have peripheral artery disease, you should be on a max potency statin unless you really have advanced age or have other, real limiting reason. And so I try to get everybody on either Torva 80 or Rosuvastatin 40. So that's universally in my clinic now. And then I still check LDL and cholesterol levels. And if they're still really high, Zetia is so accessible that I try to add them on. And there are sub-studies of PCSK9 trial that demonstrated for people who have peripheral artery disease and are on PCSK9 inhibitors, they do have lower risk of limb events. So it's a great option. It would be unique where they're on a max sten and Zetia, and I'd send them over for a PCSK9. So they would have to really have an LDL greater than 100 and really advanced PAD or other cardiovascular conditions. But most of the time I feel comfortable with them just being on a max potency statin. And then ideally we'd like to get everybody under 70 if possible, but that ends up being a little bit of a negotiation because, again, the classic PAD patient typically doesn't have great health literacy and doesn't usually come from a very high socioeconomic background. And so it's a little bit of choose your battles in this population, and getting them on the right therapy and getting them stopped smoking is already oftentimes an achievement that we take our wins when we can get them.
And then the next medication you mentioned was they should be on an ACE or an ARB. I guess why the ACE or the ARB? What's the evidence behind that in this population?
Yeah, there are several studies that have shown that amputation risks are lower for patients who are on an ACE or an ARB versus no therapy when hypertensive. So that made its way into the guidelines a while ago. And I think many of us, again, who practice in cardiology see the global benefit of ACE and ARBs.
I just wanted to get your thoughts on any preferred medications for glycemic control in this population, and is there a role for SGLT2 inhibitors? I think a lot of people were really scared with the black box warning about amputations and wanted to know your thoughts on that.
Yeah, so great question. I love that one. I always say these names wrong, so you guys get to make fun of me. Canagliflozin. I don't know if that's right, but yes. So that was the one. I always call it the C1. That's what I say when I try to explain this to people. We've all experienced how important SGLT inhibitors are to cardiovascular health now, and diabetes in particular. And I am a strong advocate for that medication. It was quite frustrating because, as mentioned, the C1, as I'll call it now, had a trial, and in their trial there was this signal of greater risk of amputation among patients who were on that agent. Now, that theoretically wasn't making sense. Some people thought that the diuretic effect of SGLT2 inhibitors in patients who had more advanced peripheral artery disease was resulting in this. And it was, interestingly, not seen in trials for other SGLT2 inhibitors. So there's a big investigation on this, and they went back and looked at several other studies as well as some real-world evidence, and couldn't reproduce this harm signal. And so it ended up, it had an FDA black box warning for a moment, and then that was taken off. And so I'm pretty liberal about people staying on their SGLT2 inhibitors. I think that right now the data supports the safety overall of SGLT2 inhibitors in patients with peripheral artery disease.
So now moving on to the Cilostazol, I think all the medications we talked about are the ones that prevent cardiovascular events, help your like overall cardiac health. And I think the Cilostazol, we're like taught that it's the one that improves like function and quality of life. I think just starting with like general thoughts on Cilostazol and what's the long-term efficacy of Cilostazol.
It's really important to understand the agent a little bit. And so Cilostazol has been around for a long time, and its mechanism in peripheral artery disease hasn't been completely understood. The feeling, like if you ask people how it works, it's a PDE3 inhibitor, but people don't really know why in the lower extremity it works. Some people tell you the platelets stick less to each other and it makes the blood thinner. Some people, it has a little bit of vasodilatory properties. The data are older now. And the biggest issue with Cilostazol has been tolerance. And so there are enough data that has kept Cilostazol in the guidelines, in particular because it's the only medication that's approved right now to improve the symptoms of claudication, in particular walking time and walking comfort. There used to be pentoxifylline, which is no longer guideline recommended. So Cilostazol is pretty much our only opportunity on a pharmacologic, a medical therapy basis to improve someone's walking with a pill. That's what I tell patients. Now, what I counsel my patients is there's about a 15% chance that you're going to improve your walking with this agent, and about 50% chance you're either going to have a headache or diarrhea. And so that's a little bit of made up numbers based on my own experience. But the hardest part with the agent is it's not effective in everyone. And sometimes people can't perceive if it's effective or not. But it's almost universally going to cause people to have some either headaches or neurologic distress or GI distress. Now, that distress can get better with more time. And so, I usually encourage people to try it for at least 2 weeks and see if they are having any distress, that it wanes. But that's a big reason why it's not more commonly used. The dose is 50 milligrams twice a day or 100 milligrams twice a day. We often go straight to the 100 milligrams twice a day, but some people like to try to titrate up to 50 milligrams twice a day. And I'm sure someone will hear this and tell me over email that I should go slower. But a lot of people tolerate just 100 milligrams twice a day. And I have this unique population of older women with symptomatic claudication who are quite constipated at baseline, who love Cilostazol because their bowel habits become more regular. And then oftentimes they get a little bit of benefit. So that's been one population where I've seen a lot of symptomatic relief. But the reminders for Cilostazol, though, are it has a box warning for anybody with symptomatic heart failure. And it doesn't necessarily specify low EF versus preserved EF. So if anybody's had a diagnosis, hospitalization, or treatment for symptomatic heart failure, we don't use that agent. And also, you'll see it kind of be lumped with antiplatelets that it can increase the risk of bleeding. I have never really observed that. And I've kept people on triple therapy with Cilostazol, and it's been fine. But if there is any concern about bleeding, it is something to keep in mind that might not be the best agent. In terms of durability, you asked also, I didn't comment on that. If it's working, people stay on it for a long time. And again, before we get people even having a discussion about whether a surgery or endovascular treatment is needed, we want to make sure that everything that has been done for that patient to treat them has been exhausted. And so we try to always get them to at least trial a course of Cilostazol before having a conversation about moving on to the next step in their treatment regimen.